My name is Reid. I co-lead RISE, which is one of the OHT support partners across the province. And we know many of you providing coaching supports and many other supports to Ontario Health teams. But we're going to start at the beginning and just talk about OHTs and their intent to their purpose to begin with. OHTs are responsible for, at their core, responsible for managing the health in those attributed populations. Some of them are relatively small and some of them are very large, and then integrating care. So they're actually responsible for managing population health and integrating care across the sector. And just the recent ministry announcement anchored in those concepts again just a few months ago. OHTs will continue to integrate care and use equity-based population health management approaches to deliver better health outcomes and provide better experiences for patients. So this is where our end goal is. And there's many parts to building the OHT capabilities, and you've been to many of our learning events before, and we talk those building blocks. Population health data management requires data, and you're absolutely right. It requires data to be able to do that. And the second point that we often hear is we've got very many pressing concerns that OHTs are required to deliver on a lot of promises over the next while. Digital initiatives. They report on measures for CQIPs, and now the introduction of clinical or care pathways for specific conditions are all on the expectations for OHTs for the next few years. But what we're going to talk a little bit about is how you can integrate these requirements into your population health management approaches, because indeed these are the building blocks, or some of the building blocks for population health management. Okay. Next slide. Remember that OHTs at the end of the day are really local, integrated, and accountable care systems. And so just a definition for everybody, those new to the OHT world, OHTs are often defined as primary care providers, specialists, hospitals, home care providers, and other healthcare providers that come together and agree to be held accountable for coordinated, quality, equitable, and value-based care for a population that they serve. And their real job is to build mechanisms to proactively, and you'll hear that over and over again, to coordinate and provide timely, efficient, and person-centered care. And as we talk through patients with particular diseases, we've got to remember about person-centered care as well as disease-specific care. And together they're held accountable for the quadruple aims for their attributed population. Population health experiences of both the workforce as well as patients and families, and around efficiencies, all with an equity lens. And then as you recall, RISE and the HSPN and many of the other Ontario Health Team support partners are really helping OHT learns the steps in population health management. And this is the 5-step model that we've introduced in Ontario and that we're all using in different, it's a very generic model that you can apply to different populations, but it's a general approach to take. Just to briefly start, the first step is really around identifying who the population is. Who is it that we serve in there? Both the people who come in the door and we know well as the people who might not, and we actually don't know, but we're actually accountable for them in our attributed population. And then it's really understanding the needs of those patients and populations using data to understand the attributed population. And we've had many webinars about understanding about the population you serve. The second step is really around segmentation then. It's really to try to divide people into different categories based on needs, risks, and barriers to care, so that we can develop care models that are particular for the different subpopulations that we serve, often called priority populations, and so we can actually deliver on the promise to those subpopulations. So it's segmentation based on needs, risks, and barriers. Once we've segmented populations, then it's all about designing the mix. It's around bringing evidence-based care into the mix and co-designing person-based pathways that are tailored to those particular segments and adapting them to be equitable. Then next, it's really around implementing these co-designed care pathways. We've spent a lot of time talking about co-design at the RISE and HSPN events, and we can certainly help people around the mechanics around co-design. Implementation is really around reaching the entire population so that we actually reach all the attributed population, not just the ones who come in the door, and then gradually learn by monitoring, evaluating, and changing. So that's the population health approach, the population health management that we've been applying. So let's dig in a little bit more. This is just a schematic that we currently use a lot, and you've seen that a bit. We leverage the Kaiser risk pyramid. So this is the Kaiser risk pyramid to really think about attributed populations and subpopulations, their risks, needs, and barriers, and connect them to the care model design. This picture represents an overall representation of a general population segmented into four different groups: healthy patients, rising risk, increasing complexity, and high users. And as you move up this pyramid, luckily the size of the levels shrinks. But as you move up the pyramid, the health risks, the equity barriers, and the medical complexity increases. And that means that you also have increasing needs for clinical, behavioral, and social support systems. So as we think about populations, we have to think about all of these people and all of their different needs as we move up the risk pyramid. Each of the case studies that we present over and over again follow this approach for segmentation, and this is a general framework that you can use for population health management. So let's move on a little bit beyond segmentation to really around care model design, which is the next pathways. Is really then it's all about co-designing care models, bringing the best evidence to bear. And actually designing care models for particular segments of populations that we serve. And today we're going to be talking about persons with diabetes, those that have relatively that are relatively stable, as well as those that have really substantial medical complexity because of a variety of additional medical conditions and social issues. And within the care models, we have embedded care pathways. And I just wanted to anchor on this term a bit because we're going to hear this over and over again about care pathways. Care pathways are an absolutely essential part of care models, okay? They are really the steps taken to deliver a care process that includes social care as well, along the entire patient journey for the duration of their condition. And with chronic illness, it's around they have no end to their condition. And remember that the care pathways are always girded by clinical practice guidelines that we agree to, and about clinical standards that we'll see from places like health standards, for instance, from Ontario Health. Are embedded within clinical guidelines or within care pathways. Sometimes you'll hear the term care pathway also synonymous with clinical pathway, and just to know that we're referring to the same thing here. And then care pathways are really the who does what, when, where, how of delivering care across to particular populations of patients within the care model. And then care models are larger than that. Care models are really systems of care that are often embedded with multiple care pathways and processes inside. There are very often very person-centered, include other components of care pathway, of components to enable care pathways. So for instance, the provision of decision support tools for physician offices, the deliver of self-management support resources for patients directly. And they often now start encompassing whole person care. So for instance, making sure that patients with diabetes or persons with diabetes also get their chronic care needs met, such as breast cancer screening and colorectal cancer screening. And so care pathways fit within care models, and they're based on general clinical practice guidelines and quality standards, okay? They fit, as you can see in this diagram, they fit in our population health management cycle, really in this co-design of care model phase.